So without further ado, I'm going to do a brief introduction, and we'll then introduce Dr. Ast and Dr. Dabakala. Okay, so as we said, Dr. Ast, he's a superstar who did some training at special surgery, so I know him very well. He's at Mercer Bucks Orthopedics in New Jersey, and Dr. Shri Dabakala is at Ortho Bethesda in Maryland, using both Neoline and Uniline for his joint replacements. And I'm from New York City at Special Surgery. Okay, well, so when we go to meetings and we talk about alignment, it's often debated what's the optimal alignment for a total knee replacement. And whatever you decide is your correct target, I would think we would all agree that as surgeons, the bone cuts and component position are both critically important in the function and survival of a unicompartmental knee and a total knee replacement. These factors will influence the patient's function, the wear of the implant, and implant longevity. So we certainly think that they are important factors in our results. And the reality is that in all aspects of our lives, I think we're always trying to reduce outliers. So when we look at, for example, a golf swing, we're looking at trying to decrease those outliers from our planned and intended ball position. And there is technology that we are all familiar with, and I'm guilty of buying lots of gadgets to try to decrease that outlier factor in golf and trying to hit that sweet spot. So really, my question is, why aren't we doing the same thing in surgery, and especially for our patients where it's really much more important? And that's really the basis of Ortholine technology. For those of you who may not have seen it before, it's a handheld navigation unit, so it's imageless. It doesn't require line of sight. It doesn't require preoperative imaging. It uses accelerometers, gyroscopes, inertial detectors, just like in your smartphone, to communicate between a reference sensor and a display unit, just as shown here. We agree, I think, to some degree that alignment is important in total knee replacement. Multiple studies have shown that tibial malalignment is a risk factor for aseptic loosening, and this classic paper by Berend and Ritter showed that if you have greater than 3 degrees of varus tibial alignment, it's associated with a 17 times greater risk of revision. And when you stack multiple factors on top of that, such as a heavy BMI of greater than 33, which is really not that big in these days, you have 168 times greater risk of failure. So certainly tibial malalignment is something we want to avoid during our total knee replacement. Femoral alignment is not as well linked to implant failure, but there is some data from a similar paper that greater than 8 degrees of valgus alignment on the femur will lead to failure through instability. And we all know that conventional guides where we're putting an intramedullary rod relies on basically the placement of that intramedullary rod, and we generally cut at about 5 degrees with a mechanical bushing. What I found interesting was that a study done by Dennis Nam, who's a fellow at HSS and is now at Rush, was that 30% of patients have a distal femoral mechanical anatomic axis outside of 5 degrees, plus or minus 2 degrees. So if you look in this picture, this patient's distal femoral mechanical axis compared to their anatomic axis is 11 degrees. And I'm not aware of any conventional system where you can dial it up to 11 degrees and achieve that cut. So that's where I think Ortholine can really help you. So basically, navigation, as we've all heard the promise from before, is that it's going to improve our implant positioning, it's going to improve the alignment of our total knee, it's going to make the kinematics better, it's going to improve longevity, it's going to reduce complications. The reality is that up till now, the large console computer navigation has been extremely expensive. It relies on arrays, line of sight, it's kind of disruptive to your workflow. And other systems which require preoperative imaging require the cost of additional studies as well as time to plan it. We have seen multiple studies in the literature that show if you use computer navigation, you will improve overall limb alignment and reduce your outliers. So multiple studies will show that basically if you use navigation, you can accomplish about 90% of your knees within plus or minus 3 degrees of your target, whereas if you use conventional instrumentation, about a third of your knees will be outside of that window. However, there's a study from the Mayo Clinic which looked at a group of outlier positioned knee replacements and a group of well-aligned, mechanically aligned total knee replacements, and they looked at 15-year study, and basically they didn't find any difference in the survival between the well-aligned group or the outlier group, but it did not account for function or clinical scores. So they didn't see a difference in implant survival, but they also didn't look at clinical scores. If we do look at some studies that looked at clinical scores, here's an RCT of patients either having navigation or conventional knee, and this did not show difference in clinical scores or patient satisfaction. So really there are several arguments against navigation, that it's expensive, it's been time-consuming, and really what's the benefit? And I agree that previously navigation was not ready for prime time, and that I think has changed with the knee-aligned technology. And as we mentioned, it's accelerometer, gyroscope-based, it's handheld, so it gives you intraoperative information right as you're doing it in real time, and it's really seamless with your conventional, seamless with your own workflow. It can be used for both the femoral and tibial cuts in a total knee replacement. It's compatible with all implant systems, and there's no large capital expenditure for a large console unit. I consider it somewhat navigation light. It gives me what I need. It's not going to give me overkill in terms of all the bells and whistles of large console navigation, but it gives me really what I want, which is the coronal cuts and the alignment of the knee, and it gives me the real-time information. And essentially, it's a sensorized instrument, and you'll see as Mike goes through how it works, how it basically gives you that real-time information. Study done at HSS by Dennis Nam won this award in 2013, doing an RCT comparing knee-align versus conventional guides. Essentially found that the knee-aligned tibial cuts were much more accurate, so greater reduction in outliers, and the time to use it was very minimal. It's only about 3 minutes, so it can be very quick to use. He also compared it to results using large console navigation, so one of those big, expensive line-of-sight large console navigations, and there was no difference in the alignment, whether you use the handheld knee align or using the large console navigation. So really very accurate, comparable to traditional navigation instruments. And this is really, I think, a very interesting paper. This was published in JBJS in 2015, and basically looking at the Australian registry, where there is a very large adoption of computer-navigated knees. So in 2012, for example, they had almost a quarter of their knees done with computer navigation. They found revision rate at 9 years to be lower in patients undergoing navigated knees compared to conventional knees. And that's shown here with a 6.3 revision rate for navigated knees versus almost an 8% rate for conventional knees. So this is really the first paper on a large scale to show a significantly lower revision rate for loosening and lysis if you use computer navigation. That's very compelling, I think. Finally, I think knee-align allows you to really intraoperatively customize your cuts for each patient's alignment. So for example, a valgus knee, you can cut them in a little bit less valgus. Somebody with constitutional varus, you can cut their tibia in a little bit of varus. And it works with all kinds of techniques, anatomic or mechanical alignment targets. It works with gap balancing and measured resection, because really the foundation of any technique is a proper tibial cut. And additional support comes from all around the literature. Don't just take our word for it. There are papers from all over the world now duplicating and demonstrating similar results where the coronal alignment and sighted alignment are greatly improved using this handheld navigation system. So it has been validated in many people's hands. So with that, I'll just take a brief second or two to talk about unicompartmental knee replacement. So the data that I've just presented is certainly relevant to total knee replacement. What about the uni? Well, the uni, and Dr. DeBacala is going to talk about that, I would say alignment is arguably more important, and we have a smaller fixation area in both the femur and the tibia. You have a narrower target because you don't want to overcorrect and overload the opposite compartment. So certainly I think alignment may be even more critical in a unicompartmental knee replacement. And this is a paper that I came across from Journal of Arthroplasty in 2016 from Korea. And they did a randomized controlled study where they navigated about 35 knees and did conventional instrumentation for 35 uni knees, and they found fewer outliers. So you see in the navigated group they had about 17% outliers as opposed to almost 50% outliers in the conventional group. They didn't find a difference in the revision rate, but they did find improved clinical scores in the navigated unis in terms of HSS knee scores, visual analog pain scores, and the WOMAC. So that's my introduction, and with that, I'd like